Reminder, I'm David Kinney, Head of Policy here at Environmental Health, and I'll just try to canter through exactly where we are at the moment in the process of setting up England's new public health service. And this slide is for you to admire the flexibility of our unwritten constitution in the United Kingdom, where the government has pushed to the limit their executive power to actually start making all the changes for this new system in advance of passing a law through Parliament that sets it up. And when it comes to the next stage, historically a local authority might have been in the town hall waiting for the government guidance on how to implement the new law, but they will wait in vain for guidance in this case, because on this subject at least, the government really means it that they support localism, and it's for each local authority to make their decisions according to their local priorities. Now I know lots of you can come up with examples of the government not meaning what they say on localism, but on this one, ministers in health certainly seem very keen at the moment that localism will be it. Now that is fine, it just is that those people making decisions at local level could do with a little bit more clarity before they start to make their plans of what the foundations are on which they're building their system. So it would be helpful to have a law that really did exist, and it would be helpful to have the kind of information that the government is promising but hasn't yet arrived. So the outcomes framework for public health, the operating model for Public Health England, the vision of local government and the role in local government of the directors of public health, the funding system, of what the money allocations will actually be, and what is the workforce strategy. All of those are documents the government is due to produce sometime soon. Mike said everything that's needed about the Marmot Review, but just to point out that we have as a society in the past made genuine and creditable efforts to reduce health inequalities, sometimes policy initiatives, sometimes more money, sometimes both. But the point about Marmot is that all the past efforts just have not worked in reducing health inequalities, and that's why it has to be something different, something more high-powered than has happened in the past. And personally, I obviously welcome, being from environmental health, the reminder about the importance of the wider determinants of health, and also being concerned about the future of our planet and our existence on it. I'm very happy that they did point out the importance of sustainability as part of the public health agenda, and reminding us all that social justice is an important part of why we do the work that we do. I do want to remind people that the Health Select Committee has just published the second report on public health, some very useful recommendations in it. I think probably some of them will influence some more amendments to that bill, which is currently in the House of Lords, and so it will make a difference. It is, in terms of getting everything ready, a little bit late in the process now, but it does make some helpful contributions to the debate on some of the key issues where there is a lack of clarity at the moment. The government, as you may know, has 2 months in which to give a written response to the Select Committee's report. There's a lot still to be done about Public Health England. For me, the most interesting thing is the change in language by the government about the presence of a Public Health England. If you go back to the beginning of the process, it was about some small dedicated unit in the Department of Health that was going to give the direction for these local authorities to take localism and run with it. But now there's talk about 4 hubs around the country and a number of local units below the hubs. Suddenly it looks a lot more like the structure of the Health Protection Agency at the present time. It's quite interesting to see how that has developed. My own kind of thinking about why this is happening is that it has dawned on the government how important health protection is and how important it is above the level of each individual local authority to respond when something critical, serious and widespread hits, that we are able to respond. And I think this is a kind of attempt by the government to respond, that there will be some reassurance that we can still respond at the supra-local government level. The health and wellbeing boards we all talk about a lot, and every time I go to conferences we end up the day thinking that health and wellbeing boards are very, very important organisations, and I think that may well prove the case. It is worth going back to the source, which is the bill, which can change, but in that there actually are not a lot of duties on health and wellbeing boards that actually achieve something. They encourage things, they may try to help things to happen. Most of the duties are on the local authorities in partnership with their clinical commissioning groups. That's the new joint strategic needs assessment process, the strategy that comes from that, and the duty to involve the public. But actually I think the Health and Wellbeing Board will indeed be the cockpit where those partners come together and make the decisions about all of those important duties. So I do think it will become a very significant body. But looking outwards instead of inwards about process, as I'll say in a moment, the budgets for these things are not sufficient on their own to make a difference. And where I think health and wellbeing boards will add value, if they ever do, is that they'll go beyond the local strategic partnership type arrangements we've seen in the past, and they actually will draw in people's commitment, their budgets and their strategies, so that we get a bigger kind of hit for the strategies and the budgets that we have to put in at the beginning. The funding is tight. At best, the government's rationale for the change in terms of funding is that a chunk of money is taken from the National Health Service that's spent on public health, and it's given to local authorities to spend on public health. So there isn't some gold mine about to open for local authorities, whatever they might think. And within that budget probably is the money for the health premiums, which is the incentive payment for local authorities that hit some particular goals that the government thinks are particularly important to try to hit. So what will be important is adding that money and the strategy to, first of all, the existing things that local government and NHS already do, and seeing that the strategies are aligned in that way, and therefore spending is aligned. And then, as I say, to try to draw in those outside organisations. It might be big employers in an area, it might be housing providers in an area, to see that they sign up to the same strategy and start to bend their resources to the same outcomes. A lot of people are concerned about whether this whole system will be independent and fearless. The first two of these, the CMO and Public Health England, they will be wary of their relationship with national politicians, and the others, the Directors of Public Health, Health Watch and the local government scrutiny committees, they'll all be wary about their relationship with the local politicians. I think there are limits to what the law can do to make these arrangements independent, and a lot is going to depend on relationships, on public support, on leadership at the local level for a lot of these. And I think we need to give our support to the independence of these groups listed on this slide. We have a particular concern at the Chartered Institute about the mismatch in the areas of England with two-tier local government. It's more than you might think. More than a third of the population, more than a third of the geography of England are in areas that have a county council and a group of districts. And all the new duties and powers and funding and the home for the Director of Public Health in those areas will be with a county council. But the biggest workforce in those areas to help with public health, the environmental health workforce, they're all with the district councils. We're quite keen to see some kind of requirement for the two to make sure they get their act together and they do cooperate. We say the bill should have a duty to cooperate. And in Wales, where they still have a Chief Environmental Health Officer, we have had one in England in the past, he is actually the linchpin between local government and NHS at the local level. And we think there'd be a very valuable role for such a person in our system too. We do worry that we're losing capacity and skills right now as people are shed because of redundancies, budget cuts, and actually a lack of trust in what's going to happen next, and losing faith and leaving their organisations now. And so one of the reasons we need those extra documents from the government and their vision is actually to inspire people to stay and fight and be part of this new public health workforce. And certainly something about the vision of who will be in this workforce and the work that they will do and the rewards that they will achieve will be a very important part of giving them that. When I hear ministers talk, I think it's very genuine, their commitment that we will collect data in order to make evidence-based judgments in ways that will be capable of dissemination at the relevant unit of information, that it will be comprehensible as well as comprehensive, and that it should be available for people to use at the right time. A lot of the discussion in the white paper on that subject suggests new ways in which that might happen. There also is proposed in the bill a new role for NICE. I don't know whether they're joining a crowded territory or actually bringing some reputational advantage from what they do already on the health side to the public health side as a leader and able to give guidance that's authoritative. And our immediate priorities here at the CIH are, first of all, that there should be a safe transition. We do warn against there not being enough people to do the work, that they're not ready to do the work because we didn't make the plans in time, because we didn't have enough information in time, and that we are ready during the transition when we're all kind of thrown off balance, that we can respond to a major health protection threat if there were to be one. We do want environmental health to be recognised for the role that it can give to a public health workforce. We're keen that there should be strong and lasting partnerships across the partners in